Hi, this is Marty Stempniak for H&HN Daily. CMS is testing the usefulness of bundling payments through the acute care episode demonstration. Through this pilot, CMS hopes to examine the effects of transparent pricing and quality information in the healthcare equation. Recently, I had a chance to chat with Shannon Fiser, Vice President of Financial Operations for Ardent Health Services, which has participated in the program through hospitals it owns in Oklahoma and New Mexico. Shannon, thanks for joining me today. So what were the challenges in implementing this program?
Well, I think one of the biggest challenges or risk items for us was processing those Part B claims for the physicians that were participating with us. That was something we were very concerned about going in as far as being able to pay them timely and accurately. So we spent a significant amount of time implementing the technology and the process around being able to pay those claims to the providers, which is not something we normally do. Probably the biggest item other than that may have been just the communication with our staff. We had a lot of education that we had to do for the clinical staff because they were going to be interacting with these patients on the front line, so they were the ones really receiving the questions from the patients. So we spent a lot of time with orientation for those clinicians that were part of the program as well.
So what worked? What were the biggest successes?
Well, I think for me, the thing that's come out of this most importantly was just the collaboration we've had with the physicians. We certainly were able to put more structure around how we interacted with the doctors from both a clinical and a financial perspective. So there's definitely been more engagement with the physician partners around the program.
What about what didn't work?
I think some of the maybe our protocol type initiatives that we've tried to implement have been slower to come into our our standard operating procedure. There's been multiple committees and some physician input and obviously a lot of opinions around some of those changes. So those have been somewhat of a process to get through implementation with those.
So talk about why you're not extending the program in cardiology at Hillcrest, but you are in orthopedics.
That really boiled down to the model we have with the physicians that were participating in the program. The cardiology physicians and the cardiac surgeons are all employed by our system in that market. So we felt like that collaboration and working together on clinical initiatives and financial management of that service line, we had a fairly tightly controlled environment there, so we just didn't see the need to go forward with carrying the administrative burden of continuing to run the program since we already had that connection built with the employed physician model.
So why did you find that case managers were so important to this program?
I think what we discovered was we needed one person to interact with the participants in the program. It was easier for us to give that one person the education they needed and them have constant, consistent touch points with the patients to be able to answer their questions or provide them additional information on the program versus trying to have multiple departments, multiple staff members interacting at that level with the patients.
So what's next for you guys? What's on the horizon?
Well, we've applied for the Bundle Payment for Care Improvement Program. We're hopeful that our application will be accepted for that. So we would like to see this model expanded into more DRGs and additional service lines. In some cases, we've looked at spine surgery, for example, as something we would expand this into. So we certainly see some opportunities for more physician partnerships through that program.
Shannon, thanks so much for your time.